give all the tips in this 6-7 minutes. I'll just run you through some situations which we have collected over the course of so many years. This is a patient who had two different patients who had unusual reaction, and the prime aim here is to differentiate between sterile versus infection. And I'll show you what we did. I loaded these patients with steroids by all the routes, topical, in fact, intravenous also I gave, and this was the result that this patient had at the end. So moral of this story was that when in doubt about tasks, and follow this patient very closely. In fact, this patient was in the OPD for the whole day. This was another patient referred for vitrectomy, but what changed my mind against vitrectomy was this whitish color lens droppings, which I thought, although there was limbus to limbus corneal edema here, again treated only with steroids, no interval antibiotics, patient did recover good vision. So when when the scales tilt towards TAS, you should load the patient with steroids. In contrast to this patient who has all the telltale signs of endophthalmitis, immediate interval antibiotic injection. And most of us are still persisting with Vanco and Cefta, but I think sensitivity of Kefta is decreasing, and I think more newer antibiotics are being tried in gram-negative organisms. This chart, I think, still useful to prevent dilution errors. It should stuck to the wall in the operation theater. Always you need to decompress with the help of vitreous biopsy. That's the best. Otherwise, I don't advocate vitreous aspiration at all, but this has negative consequences on the base of the vitreous. And topical treatment also, you see, we do persist as corneal ulcer patients get concentrated cefazolin, concentrated tobacin, and cycloplegic drops. So this was that patient which I showed, a 73-year-old gentleman. After one interval injection, this did recover good vision at the end of 3 weeks. But everybody may not be so lucky that you may have a partial response, or the culture sensitivity report may come by that time. Normally, I do not like to repeat intravitreal injections if the patient has not responded, unless the culture sensitivity report reports the other way around. Or if there is a heavy load, something like this, unlikely to respond to intravitreal. So in situation number 3, like this, or situation number 4, directly prepare the patient for MIVS, because in today's era, this has yielded good results. And whenever we eye enter into, say, the vitreous cavity, I do not do a half-hearted job, always do a complete radical vitrectomy, even at the cost of creating a posterior hyaloid PHF detachment also. But before we go inside, we always have to clear the anterior chamber, primarily because if you don't do that, this is one of the biggest tip, that you use an AC maintainer, take care of the fibrin in the anterior chamber with a separate stab incision after you have injected visco also to protect the endothelium. After this has come out, this membrane over the surface of IOL, then only you go inside and do a definitive job. Because if you don't do that, it's very difficult to do a precise job in the vitreous cavity. In situation like this, where there is no limbus to enter, so what we prefer generally is to do a pars plana approach for clearance of the anterior chamber. And the way we do it is that from the pars plana, after you have this 6 mm cannula straight entry, no angled entry, from the pars plana we make a hole in the iris, and after you have made the hole in the iris, then with the help of various instruments, you can tease away all these exudates over the surface of IL, over the surface of iris also, and then go inside and do a depression vitrectomy. This does help in a lot of these patients who have chamber full of exudates and we can't enter the chamber also. Other thing is question or trap is whether we should remove IOL or not. In a mild endophthalmitis, no, but in patients who have very severe endophthalmitis, like I showed before, or a recurrent kind of, or fungal, we generally end up removing the IOL. And this is one patient who had presented with corneal abscess, and this was the lady who had already received multiple injections, and she presented with corneal abscess, and we did this entry. First principle always to clear fibrin from the anterior chamber and remove all this muck over the surface of IOL. Also sever all the connections between the abscess and the intraocular cavity. And in this patient, we ended up removing the IUL, and this IUL had one haptic which was missing, meaning there was eventful surgery at that time. Now the pupillary area is aphakic. You become more bold and remove away all the exudates, do suturing also, and do a depression vitrectomy. And at the end of it, I injected oil in this particular patient. And this was the result of this patient at the end of 4 weeks. Oil still inside, but BCVA 624 at that time. Fungal endophthalmitis generally is a diagnosis after we make, is a diagnosis of after we fail with the first injection. And although we have, voriconazole and other zoal derivatives, most of these patients end up with vitrectomy and revitrectomy. This patient already had multiple vitrectomies, and still there was recurrence after a couple of months. The only thing which we did was because it was already a vitrectomized eye, we peeled off the hyaloid face because there are colonies always collecting behind the hyaloid. So this made us believe that you should try and remove hyaloid also, because sometimes you can have exudates behind the hyaloid also. So you can't do a core vitrectomy and come out in all the patients. This was the result of one of the fungal proven endophthalmitis after oil removal. P. acne endophthalmitis, again, you see that plaque over the surface of posterior capsule. Or in such patients, there are 3 situations. Sometimes in the bag, vanco will help, as helped in this patient. In the bag, vancomycin, because intravitreal vancomycin may not reach inside the bag. This patient had a vitrectomy done, but we didn't remove the IUL, and fortunately recovered good vision after 6 to 7 weeks. In this patient who was a medical professional, and ultimately we ended up removing the IUL because although the vitreous part was not so difficult, but more difficult was to remove this IUL and all the bag itself, because that took actually more time. Once we removed the IUL by mobilizing this, each and every bit of the capsule, because pupil was not very big, so you have to use the suction part, tease the capsule bag in front, and that took a lot of time in removing the entire bag. And ultimately, once this entire bag, we still went inside, did a total complete vitrectomy, wanted to be sure that we have done a radical vitrectomy. And that ultimately led to a remission. She did not have much recurrences. Once the cornea gets involved, you have to take help from cornea colleague. And in this situation, this was where we used a temporary keratoprosthesis. Because all this melt is taken care of, the keratoprosthesis is fitted, and then you enter into the vitreous cavity, do a total complete vitrectomy, and then after that, you fit in the graft. So these were a couple of situations which I thought I'll share with you, and some tips of vitrectomy. These are the 10 tips which I wrote down a couple of months back. That suspect, react, differentiate from TAS. When in doubt, have a peer review, prompt injection, and regular daily review, in fact. Pay attention to culture report, early vitrectomy. Don't delay vitrectomy too much, otherwise things may become irreversible. And refer always to a higher center and document, because this will save you in the court of law. Thank you very much for your kind attention.
Thank you, sir. I think the last slide summarizes the entire thing with giving the most important 10 tips for management of endophthalmitis. But since we would be having a lot of anterior segment surgeons also sitting here in the hall, before they refer a patient for management to a retina surgeon, would you advocate that they give the intravitreal themselves?
So this is a fairly frequent situation with us, and all credit goes to them. In fact, one recent patient I had operated in Delhi itself. So I told, you give intravitreal injection. So they gave, but the patient responded to that. I didn't do anything. In fact, I just followed up the patient, and patient today is 612. So all anterior segment surgeons should know that art and trick of giving injections, because the only thing which hurts is they will give a Avastin or Lucentis, but they sometimes will hesitate to give antibiotics. But in this particular patient, believe me, Manisha, the patient responded because that surgeon did a good job.
So I think that is a game changer if you give an intravitreal on time.
I think all of us have to propagate and make them feel confident that they can give it.
No, certain times the low-grade endophthalmitis, which is appears very fine and very little endophthalmitis that has more recurrences actually. The staph epidermidis and P. acne, those things require almost 4-step approach where you showed the last step, that removal of all the bag and IOL, but short of that, intra-bag injection of antibiotic can also be done as a trial. Actually, there is a good study about this, and
So,
in that,
Dr. Ajit,
90%.
I did show that. I don't think so you saw that. I showed 3 patients. In one patient, in the bag antibiotic did help. But in the third patient, it did not. She already received in the bag injection 2-3 times in Agra and then was referred. So first patient of mine, P. acne, it did respond to in the bag vancomycin. That is the first step.
Yeah. It's a 4-step procedure, so that need to be explained to the patient. Otherwise, certain times if we seeing mild endophthalmitis and good prognosis, it probably may not work in the clinic. Thank you, and we will invite Dr. Tara Prasad Das to present his antibiotic susceptibility in endophthalmitis management study.
Good evening. I do not have any financial disclosure connected to this topic. Today, both AMS standing for antimicrobial susceptibility and AMR standing for antimicrobial resistance, very important to study and periodically study so that in a treatment of any infectious disease of the body or the eye. We're talking about the EMS. EMS stands for Endophthalmitis Management Study. It is a multi-center prospective randomized clinical trial. This is registered under the Clinical Trial Registry of India, number given there. We are running it now in 4 centers in 3 states of India. Sample size calculated is 436 and is completely funded by the Hyderabad Eye Research Foundation of L. Prasad Eye Institute. The flow diagram shows that how do we recruit and how to treat patients of endophthalmitis in the EMS. It does not depend on what vision you have got. We said that what is your inflammation score, we'll talk a little later. Those inflammation score of less than 10 will do a TAP standing for intravitreal injection and vitreous biopsy. And then of those who have got inflammation score of more than 10 will be treated with the vitrectomy with antibiotic injection intravitreal. Either side is randomized to 2 kinds of combination drugs intravitreal. One is vancomycin ceftazidime used by EVS, other is vancomycin imipenem. All the eyes will receive dexamethasone intravitreal. Those found culture or microscopy of fungus positive, they will be also randomized. They're randomized to receive either intravitreal voriconazole or amphotericin B. These are study drugs for the EMS, and the important thing is this, that we had imipenem initially designed, but then after interim analysis for some reason, which we will not be able to complete this today, you already published though, we changed to colistin with all the doses written there. So intravitreal, topical, systemic, and oral, all mentioned here. We're talking about inflammation score. Inflammation score is measured by the 4 cardinal tissues of cornea, interchamber, iris, and vitreous, where you can actually examine by slit lamp or ophthalmoscopy or ultrasonography. They're all into 4 cardinal points of 1 to 4, 0 being all clear. And they've shown that how do we cornea example, transparency, and abscess, and similarly. In case we find that one area is completely opaque, let's say this is completely opaque, you can't examine anything further, then allows to add certain points. Then arrive at a particular number on best that and they look at the X number, then it's less than 10, you do a TAP, more than 10, you do a vitrectomy with antibiotic injections, etc. While the inflammation score used for a large randomized controlled trial called dexamethasone trial in 1919, published in British Journal of Ophthalmology, we revalidated with the slit lamp photos, just not the examining doctor, and we also found that they are stable and inflammation score is reliable, reproducible data, so it can be validated further. In the microbiology of EMS, we did not rely only on traditional microscopy, culture, and susceptibility, but also did a molecular techniques of polymerase chain reaction, Sanger sequencing, and next generation sequencing. And I will show you that how this is more important or equally important in addition to traditional microbiology workup. As of November 2023, because we are not allowed to analyze data whenever we want, because this is a randomized control trial, there are a lot of ethical issues. By 2023 November end, we had recruited 369 of 436 patients, of which 350 had a culture, and this is the number of patients who had a PCR, and this is the NGS. There you found that while culture was only positive for 30% of the times, PCR was positive for 59% of times, and this is called micro-positive, standing for both combined PCR and culture. It was 58% positive, where gram-positive cocci and gram-negative bacilli were nearly equal, and fungi was roughly 11.5%. This is the susceptibility report of gram-positive cocci. Vancomycin was as good as cefazolin and better than gentamicin, and moxifloxacin numbers are written there. Similarly, for gram-negative bacilli, we found that colistin was better than either amikacin or ceftazidime, and both of them are better than imipenem. So our choice of imipenem, that's how we changed, that imipenem may not be a good alternative to ceftazidime, but colistin could be better. We also found that 39% of the isolates were multi-drug resistant, and most of them belonged to gram-negative bacilli, very few with the gram-positive cocci or gram-positive bacilli. Then when we found antifungal, talking about normally used voriconazole and amphotericin B, but we found that most of them time they are resistant to amphotericin B or voriconazole, but sensitive to caspo and other things. This is the importance of the next generation sequencing. We found that those who are culture negative, they actually found to be NGS positive, and most of them were mixed infection. And similarly for the fungi, most of them were Aspergillus niger. Based on this data, which is very absolutely new, first time in presenting here, we can actually design a score of disease severity. If the iris is visible, which is called corneal clarity, is less than 2, then there is a hypopyon less than 25%, but vision is less than 2400, we call it a micro-positive because it is both sequence and culture. We call early, similarly intermediate and advanced. I will show you further data, how it happens. We also found published that those who are more than 20 inflammation score, 20 or more, most of them are gram-negative bacilli, which is shown that how high AOC and higher Spearman coefficient score. Then we saw that those who had a mild infection, most of them are gram-positive cocci, the higher ones are gram-positive, gram-negative bacilli, and those who had early symptoms, less than 2 days symptom, they had a more of gram-negative bacilli, otherwise gram-positive cocci. And then
1 minute.
And I agree with Ajit. And then we're talking about the drugs now. Then while I say that colistin is better or cefazolin is good, be careful because of the half-life of the drug. If you're giving cefazolin or colistin, you have to give it every day if you repeat. If you're giving vancomycin ceftazidime, then alternate day to 3 days. So it's important to remember. Otherwise, give one injection, forget it doesn't happen. It's very important to know the half-life of the drug. In summary, inflammation score is important. The inflammation score helps in making decision-making. Vitrectomy is based on inflammation score, just not the presenting vision, the high and ignoring it. Vanco, colistin are good drug for gram-positive cocci and bacilli. Thank you.
Thank you so much, sir. I think it really highlights that how we have to change our practice of managing endophthalmitis. I was just wondering, which antifungal would you propose as the first line now?
Good question. Manisha, of this total, we have 21 fungal infections based on the NGS. That's not on the culture. Culture is only 7 or 6 actually. And we given only voriconazole and amphotericin B, but very surprisingly, most of them are resistant to these two drugs. So we are working now. I have not arrived at a conclusion that caspofungin or mycofungin might be better for Indian fungal infection. We cannot be worldwide. So because when you talk about the antifungals or susceptibility based on your own area.
Right,
so
sir.
I cannot answer the question now, but I'm working on it.
Right.
Other surprising thing is that there is something called acute fungal endophthalmitis. Normally fungal endophthalmitis are chronic. So I'm very surprised about that. So looking at the clinical data, when do suspect acute fungal endophthalmitis? My desire is that before you get a macro report in 5 to 7 days later, can you start treating properly instead of working on something else? hopefully
And
will
so
come.
I
Yeah,
think
but
it is.
I think we have published that long ago.
We have published, he had the first author, he published it many years ago, 1999 in Nature Eye. So we have on the EMS, have published 5 papers, 6 is on the Center for Publication. But I am hoping that if I accepted, then I will talk about the acute fungal
Right.
post-cataract endophthalmitis. It's a new thing actually in upcoming Guwahati VRSI, if I have the opportunity. Depends on scientific committee chairperson accepting the paper. Thank you.
But I think we do very often see an acute fungal endoph, sir, in our setup. I think it's more to do
True, but
with
then
the-
classically we read that
Yeah.
fungal infections are late, chronic, less hypopenia,
That's the classical
ABCD. So
teaching we
classically
have.
have known
Yes.
that. So when we had a 16% fungal infection, up to 16%, then, and you and I worked together, right? We published 730 fungal endophthalmitis in India, cohort from Delhi to Chandigarh, from Pune to Guwahati,
Right.
and we know what it is, but then we will come out with a larger truth.
Look forward
Thank
to
you.
that, sir.
Thank you.
Thank you.
And currently, what combination would you advise for the delegates?
Oh, well, because we are on a study trial, we randomized to colistin, vancomycin, and vancomycin ceftazidime. Because we are in a trial, in a study. So if you say that what we'll do ultimately use, I do not know. I might prefer colistin today.
Okay. Thank you very much. And now we will go on to the next talk by Dr. Ashish Lal. He will be speaking on management protocol after diagnosis of endophthalmitis.
Before I start, I would like to say that I have been trained under Dr. Das, Dr. Ajit Babu, and Dr. Subhadra, who are all here. And my approach to endophthalmitis has been developed from L.V. Prasad. And I would say that endophthalmitis is like a war between the surgeon and the organism, where the surgeon uses his antibiotics, vitrectomy, guided by his clinical intuition, culture, and PCR, and the enemy is the organism, whether it is gram-positive, negative, or fungal. But the important thing here is that the enemy has entered our territory. We need a surgical strike. We need to be more aggressive than the enemy. We had to have the right weapon. That is what Dr. Das has been talking about. And we also have to prevent the collateral damage. That is, we have to prevent ourselves, our eye. And if our missile or our antibiotic has not worked, then what text and which one? Herein comes the role of microbiology. So there are few important considerations that guide our strategy. I will call it aggressive or slightly mild. Now, how aggressive is the enemy? Is it within 2 to 5 days? Is it a cluster? Because if we have a cluster, the cluster is usually very aggressive. It is either because of fluid problem or visco problem or sterilization failure. We have to act like a war situation in these cases. Then corneal involvement, usually again are very aggressive endophthalmitis, usually streptococci or gram-negative pseudomonas. Then presentation, Dr. Das said inflammation score, we have not objective assessment, but we say that if retinal details are not seen, vision is less than 6/60, hypopyon, pain, rapid deterioration. So I would call it like we can divide it between less aggressive and more severe infections. For milder infections, we can go with the traditional standard of care, that's vancomycin and imipenem. Vitreous biopsy by needle, I would not recommend. This is just a small video which, we can do for milder infections. We can just do a vitreous biopsy. With the help of 23-gauge valve trocar cannulas, we put the trocar cannulas. Now the infusion port. Once the infusion port is taken, we should take out some sample because that will guide us for the further treatment. First the undiluted sample, then the diluted sample. Once that is taken, we can do a core vitrectomy for 3 to 4 minutes. We can just do it by 2 ports. Once that is done, we need to inject our antibiotics. So 23-gauge with valve cannulas is one of the best because we do not need to suture it. Take vitreous biopsy and give injections. For injections, gram-positive, vancomycin works best. For gram-negative, we have an array of antibiotics like amikacin, cefta, piperacillin, imipenem, colistin. The more aggressive, the more you are active. Now I'll present few case series. Now these are the 2 patients who were operated, husband and wife together. The husband developed after 2 days and wife on the 4th postoperative day. The initial surgeon had given vanco and amikacin. Now the patient was not responding to amikacin, so what to do? For gram-positive, we know that vancomycin was working, but vancomycin was already given. For gram-negative, amica did not work, so what else do I have? My friend was in despair, so we did vitrectomy, vitrostab, intravitreal vanco, then I gave all the three, tazobactam, imipenem, and colistin, because this was a cluster endophthalmitis. And this is case 2, case 1. After 24 hours, the microbiology showed Pseudomonas aeruginosa. Now, the sensitivity came after 48 hours. Now, we had 48 hours in between, which showed resistance to amikacin, tazobactam, and imipenem, and only sensitive to colistin. That is what Sir has been saying. So, we had 48 hours. Had I not given colistin and the first go, I would have lost both the eyes. And we had an excellent results. We were lucky that we had given that in the first instance. So 2 more days with Pseudomonas, as you know, we can actually feel what can happen. So these were the post-op results. The microbiology showed us that whatever we did was right, but in the hindsight. So I would say that in cluster endophthalmitis, we need to be more aggressive, and we can give both the antibiotics. Now, there are 2 other cases done on the same day in some other center. This was presentation on the 3rd day. This is the first case. This is the second case. Now, they again are looking very aggressive. I thought it is same Pseudomonas. I'll give all the 3 antibiotics and the patient will be okay. But it was not a gram-negative endoph. You can see I gave all the 3 antibiotics. Now, the smear report in these patients showed streptococci, and gram-positive diplococci were seen. So vancomycin was already given. We did not wait for the growth and sensitivity. Re-injected vanco, Vigamox, and Dexa. Now here you can see that both in one of the patients there is corneal involvement. So what we had already injected, we were waiting that what next to be done. Now, here I would like to say that once you have severe corneal involvement, it is better to explant the IOL with re-injection. So I explanted the IOL. This is the condition after 15 days. One eye had responded beautifully. The other eye had corneal opacity, but we could save the eye. So I would say that we should not say that all patients are going to be gram-negative. There can be very severe gram-positive as well. So micro gave us the right direction. This I'm just skipping off. This is a fungal endoph. So finally, I would say that in short, we have gram-positive bacteria where vancomycin works almost all the times. We have another drug, linezolid, moxifloxacin, which can be used. In gram-negative, Cephta amica usually works 80 to 90%. Then we have other armamentarium where tazobactam, imipenem, and finally colistin. I think the safety and efficacy, sir will come up with the report and we'll all follow him. But yes, in my limited experience for cluster endophthalmitis, we need to be very serious and very aggressive. Thank you.
Thank you so much. It was a beautiful presentation, and I loved the topic that you gave. You called it war. Definitely it's war because there's high expectation from the patient. And the important things that we always note is that intravitreal injections have to be given as early as possible because we don't want to let things get out of hand. Don't wait for the culture sensitivity report in the beginning. Let it come later on. I just wanted to share 2 cases that I experienced with P. acne endophthalmitis. It is really a big mimicker because the patient presented with low-grade iritis. Most of the times, I gave steroids. Patient responded very well. As soon as the steroids weaned off, again, there was iritis. And at the end of the day, only removing the IOL saved the eye. So that is also a big mimicker, and one has to bear that in mind. Thank you.
Thanks.
And now we'll invite Dr. Mudit. He is speaking in place of Dr. Rajiv Reddy. And his topic is endoscopic vitrectomy for endophthalmitis.
All right, so good evening, and once again, thanks to the scientific committee for allowing us to talk on this. So I have already spoken in the last session on how endoscopy can help us in a lot of our different scenarios and how it can help us in obviating the problems that are caused by media like this, which will not usually allow us to visualize what's happening inside the eye. And endoscopy, because of the virtue of the fact that you are able to go inside the eye with an optical source and a camera, helps us in obviating or taking care of eyes where there is no good view of the anterior chamber, either because of corneal opacities or exudates. It also, like I said, helps us in getting away without using a temporary keratoprosthesis in a lot of these cases. We have already discussed about the endoscopy system and what it is. But what I'll show is that we also then subsequently assessed our experience of endoscopy in 33 eyes and how it helped us. The main point is that endoscopy allows us a window of much earlier intervention. Just in the previous talk, Dr. Ashish Lal was talking about how they were able to salvage the eye and get good visual outcomes because they were able to inject in time. The same way, if we are able to intervene in time and do a much more thorough cleaning of these vitreous opacities, taking care of these exudates as early as possible, it does allow us for a better outcome. So what we found was that cases which were managed relatively early in spite of poor visualization, the evisceration rates in some of the eyes had dropped, was just 3.03%, or just one eye had to subsequently undergo evisceration. Otherwise, which could have had a much worse outcome if we had not done an endoscopic vitrectomy in time. So this was one of the cases. This is actually a video of Dr. Rajiv Reddy's case where there were these dense exudates, and what you can see is that with the help of an endoscopic visualization, we were able to clear up most of these exudates, take care of all of these peripheral vitreous exudation, and also, while we can obviously take a biopsy and give IOAB, but clearing up of all of these vitreous exudates allows us a much better intervention. So now you can see that most of this retina is absolutely healthy. We are able to visualize the entire disc and the retinal structure, and all of these exudates have been taken care of subsequently. These eyes, once they improve, we can also plan for subsequent corneal interventions once the media is clear. But you can see how nicely all of these exudates have been removed, and we can visualize an underlying healthy retina. So endoscopy gives us that opportunity. This was another case where there were dense exudates, and what we can see subsequently over here in this video is that the video is moving. There, here. Is that we are able to again go inside, take care of these peripheral membranes, and it gives us an opportunity to take care of all of these exudates without causing much of a damage to the eye. It allows us a better visualization, which we could earlier not have done because of the corneal opacities, and allows for a much better intervention and much better outcomes in a lot of these cases. So this was one more case. This was a patient who had got a trauma and an intraocular foreign body along with endophthalmitis, was managed by my colleague Dr. Vivek Dave, and this is how the eye was subsequently after a month. So this is at 6 weeks. They were able to get a good visual acuity of 618 in this eye, and were able to take care of the foreign body removal as well as taking care of the endophthalmitis. So in a nutshell, endoscopy allows us for a much earlier intervention in eyes which have got an opaque media, also helps in removing these foreign bodies, and allows us an opportunity to take care of our patients at a much earlier time than what we could have done if we were waiting for the media to clear. Thank you so much.
Excellent presentation, Dr. Mudit. For the youngsters who would like to understand more about endoscopic vitrectomy, would you just explain how a person who is about to learn endoscopic, how does he manage about the dimensions of the endoscope so that he doesn't see upside down?
So that is pretty simple. Like we had shown in our earlier talk also, the initial part is getting used to the endoscope and getting an orientation done. Before you enter the eye, it becomes important for you to look at, because you are not visualizing heads on, we are visualizing end on. So you are seeing the screen and see what's there in front. So before you enter the eye, it becomes important for us to orient our endoscope so that what we are visualizing is absolutely the same as what we see on the screen. So before you enter, ensure that you focus on anything. Either you want to focus on your cornea or a forceps, and ensure that your visualization is absolutely same as what you are seeing in front of the screen. And then you enter. The other important tip is to always ensure that, because you've got a very limited view, to ensure that your instrumentation is in the visualization of your camera. That is the most important point. So you have to constantly be in a habit of visualizing your forceps or your instrument, and your camera should be focusing upon that. So you move both of them together. Normally we have a light pipe here, we are able to visualize what's happening all over. But over here, you have to move your camera and your light source along with your instrument, so that constantly you're focused on the area where you are working upon.
because of these issues, now Vistec has come up with a camera and a light pipe, which, like how we have a knob on the top of the Alcon constellation.
Yeah.
So they have come up with a endoscopic vitrectomy where there is a knob, which helps us to, we don't need to like hold a sticker and see whether it is upright or not.
Exactly.
So that's quite kind of a good change they have done.
Yeah.
Thank you.
Thank you so much.
Okay. Yeah.
So now, in these cases again, so if you have got a media which has subsequently cleared up a little bit, you can still visualize. If not, there are other clues to, if it's a case of endophthalmitis, there are multiple clinical clues which can also tell you how your patient is improving. Your cornea starts getting clearer, your AC exudates become reduced or are regressing. Once you're able to sometimes visualize the iris details and the details, the exudates start getting regressed. Those again are clinical clues. Apart from that, you will have to rely on an ultrasound B scan subsequently to follow up the exudates are regressing or not.
Can I press upon a very important
Thank you so much.
observation here? Like how in the last few years, Dr. Haripreet Arvind, Dr. Chang have come up with intracameral moxifloxacin for cataract surgery. Endophthalmitis after vitrectomy is a known phenomenon. So do we, Dr. Das, the entire panel, do we think the vitrectomy surgeon should end up injecting moxifloxacin in the entry chamber before FX or just after FX with a 30 gauge needle? Do you feel it is necessary, because that has been lately being discussed? Intracameral injection of moxifloxacin has been talked upon. Is there any at the end of the vitrectomy surgery? Is there a role of that in preventing
Vitrectomy?
Yes.
See, the thing is, you need to understand the mechanism between cataract surgery and retinal surgery, vitreous surgery. Vitreous surgery is an egress system. It actively pushes out everything. So, not many cases require an intravitreal antibiotic at the end of vitrectomy. Very less likely that endophthalmitis will come, and these cases you need to be very observant in the post-operative period, because endophthalmitis in cataract surgery can present very early, whereas in post-vitrectomy these cases to present also it will take a lot of time, and if endophthalmitis is developing post-vitrectomy, it is much more dangerous because residual vitreous only it can show up. So treatment also much different when it happens in cataract surgery than in vitreous surgery. As a routine, we don't advocate any antibiotic for vitrectomy. Yeah. Ashish Lal, wait. Ashish Lal, you want to answer? Yeah.
Actually remove the entire medium in vitrectomy, just the peripheral skirt is there. So there is no medium for the organism to grow. So in case of these patients, if we have endoff, it's going to be very severe. It means we've actually inoculated too much in it.
Yes.
And besides, moxifloxacin as sir has shown that it's like only 30 to 40% of the bacteria are going to be, sensitive towards moxifloxacin. So probably the role of Vigamox may be questionable once the...
That's true.
Yeah. Thank you, Kajal. You want to ask some? That's what I said. No, for after vitrectomy, it is not indicated. Let us not do it, because the percentage of occurrence of post-vitrectomy endophthalmitis is very less, and it is a egress system which we were working on compared to a ingress in case of cataract surgery. Okay, with this, I hope is Dr. Rajiv Jain is there. If he is not there, we came to the end of this fifth session and end of the day of Retina Specialty Day. It is a dedicated Retina Specialty Day from morning 8:30 to now 5:30. It's a continuous, except for 1 hour we had a cataract surgery session by Uday Devgan. And I thank all the panel who participated here, and mainly this guy from AIOC Scientific Committee, Piyush. I used to scold him, but I appreciate him. Since morning, he's there along with me for this day's session. And I thank all the delegates for your active participation, and really it's made a difference for this day.
I would like to say thank you to Dr. Ajit Babu Maji, sir, who's devoted all his entire day and been there over here since morning, since 8:30.
Luckily, I don't have other commitments except for the lunch. Thank you.
Can we take a